Good afternoon, good evening, everyone. Thank you so much for joining today's webinar on home-based care for COVID-19 patients. My name is Mirwais Rahimzai. I am the Senior Technical Advisor for Palladium based in Washington, D.C., and I'm also coordinating, providing technical coordination to the COVID response work in Central America. Someone please confirm that you can hear me. My colleagues will notify me if you're unable to hear me. So the current pandemic has affected the lives of billions of people globally, regardless of their rank, race, geography, political or social status. According to the Johns Hopkins University data, more than 140 million people confirmed cases of COVID-19 has been reported, and more than 3 million people lost their lives, their dear lives globally, and we share the grief with their families and loved ones. It has been a disaster not seen in our generation. There were times when hospitals were overwhelmed, important measures such as lockdowns were imposed, and people had to stay home to reduce transmission of infection. We also know that a large number of COVID-19 patients who had mild symptoms and did not need to go to hospital, they also increased the load on the hospitals. So as much as the COVID response is a health system function, it's also a responsibility of individual families and as well as communities. Next slide, please. So this webinar is brought to you by Health Policy Plus Project. Health Policy Plus Project is a USAID funded global mechanism to advance health policy priorities at national, subnational, as well as global level. And we have been engaged heavily in COVID response in Asia, Africa, and Central America, in Central as well as South America since the beginning of the pandemic. Next slide, please. So the objective of today's webinar is to provide essential recommendations on the management of COVID-19 cases at home, and as well as strengthen infection prevention and control measures, and as well as provide information on how to integrate palliative care into the home-based care in the home environment, as we provide as health workers as well as families, provide care to patients with COVID-19. Next slide, please. So as you can see, today we are using the GoToWebinar platform. Some of you may be joining using your phone and some using your computers. If you are joining your phone and Apple, you will see some of the functions on the lower part of your phone. And if you're using Android, you can see some of the functions are on the top as well as on the lower part of your phone. And on your computer, you will see the function bar on the right side of your computer, and you can ask your questions, put your comments on the appropriate window, whichever facility you are using. Next slide, please. So in our today's webinar, the agenda is divided into 4 main sections. The first section will be mainly presentations on the role of the health worker, COVID-19 transmission, specific recommendation for patients with mild and moderate symptoms, and as well as the recommendation on palliative care. The second section would be on sharing experiences from Honduras, El Salvador, as well as Uganda. The third section is mainly around, for you to ask your questions. And the fourth section is to share with you some helpful resources. But please feel free to ask your questions whenever you're ready with your question, and post that on the window on the right side of your computer, or appropriate place on your telephone. Next slide, please. So we would like to make sure that you know that today's webinar is going to be recorded. We will also try our best to make it as interactive as possible. We will post some questions and will request you to cast your vote for the right answer. We will have 2 of those questions in our 2 presenters' presentations. My colleague Gavi will be helping me with the technology, moving the slides, and I would like to thank her in advance for doing that. If in case you face any problem, please put your question in the chat, and she will be able to read and hopefully troubleshoot any technology problem that we may have. Please turn off your mics during the presentation, and feel free again to ask any question you may have. So our panelists, distinguished panel members today are Ms. Sarah Bowski, who is the Deputy Director for HP Plus Global Project. She is a registered nurse with extensive experience in the provision of home-based care in the US as well as abroad, and is actively engaged in the COVID-19 response internationally as well as in our home state in California. We also have Dr. Sarah Rivera, who is an infection prevention control specialist from Honduras, who has been leading our home-based care activities or portfolio in that country, and not only there, but also providing advice to the to similar programs in other countries in Central America. Next slide, please. We have with us Dr. Lindsay Farrant, who has an MPhil in palliative care and has extensive experience of palliative care in South African health system, currently working with the University of Cape Town. We also have Dr. Jane Nabakoza, who is a pediatrician and public health specialist working for the Ministry of Health of Uganda. We have with us Mr. Robert Okoma, who works with the Ugandan Health System Strengthening Project as a private sector advisor. So thank you so much. I would like to invite my colleague Sarah Bowski to present her presentation. Thank you.
Thank you, Mir. As COVID-19 has changed the way we work, it has not changed the critical role that home care workers play for people with COVID-19 and for their families and their community. Next slide, please. The role of home-based care workers spans from patient and family education to raising awareness about COVID-19 to conducting patient and household intake assessments, and of course, providing care. Important principles are upheld by our home care workers, including knowing when to refer a patient to a health facility, understanding and meeting the patient and family where they are in terms of their own understanding of their situation and the needs and their needs, and of course being able to be accessible and maintaining constant communication. Home care workers also adhere to maintaining privacy and building trust of all patients and their families, as is expected by any healthcare professional. Next slide, please. Home-based care is most often initiated through either through an identified need within a community by a community member or an NGO, or as a referral from a facility. As with any illness, it's imperative to know under what circumstances home-based care is recommended. And if somebody's unsure about that, the home care worker will always ask another qualified provider, or if still unsure, simply refer the patient to a facility to either outpatient or inpatient care. Some of the most common situations whereby home care is recommended include when the patient has mild symptoms, or is not in one of the higher risk categories, such as someone with heart disease or someone who's immunocompromised, where we would recommend clinical care through a facility. Likewise, it's important to know when to refer to outpatient or inpatient care, such as when there are signs and symptoms of moderate or severe COVID-19, including, for example, decreased oxygen saturation or respiratory care. What can be challenging for home care providers is when a patient refuses to go to a clinic or to be hospitalized, even after providing them with all of the needed information despite a declining condition. Here is when the principles of providing full information on potential outcomes and meeting the patient where they are is essential. I'm sure a bit of this will also be discussed a bit during our palliative care portion of our session today. This slide from the home-based care manual that you see here can easily also be used as a pocket reference for home-based care workers or as a reference card for patients and their families. Next slide. While similar to other situations in which home care is provided, given the infectious nature of COVID-19, it's important to ensure that not only the patient, but those taking care of him or her are aware of the following, so that they have the best outcome possible and to prevent any forward transmission of COVID to others. So these include not only not leaving the home unless seeking medical care, but adhering to all standard prevention measures, including isolation in a separate room where possible, wearing masks in the home, and asking a family member for help. Next slide. So given the critical nature of COVID-19 and the rapid pace at which a person can decline, it's important for everybody to know, the home care worker, the family members, and everybody else involved in that care, to know the signs and symptoms of when someone needs to seek immediate medical attention. And these, again, can be easily identified once people know what they are, and being written on a simple card and brought into the home is really important. Next slide. So now we'll talk a bit about transmission, something that we hear a lot about, but we also know is important to reinforce. So before we do that, we're going to do the first, of our audience interactive activities, where we will be able to pull everyone's answers anonymously. So we ask that you simply answer the question, when a person has COVID-19, why is it important to ask about their contacts to the best of your ability? Great, thank you. So clearly we have the majority of people chose the correct answer, which was that all options were correct, that to slow the spread of the virus, prescribe COVID-19 diagnostic tests to contacts, and communicate symptoms and warning signs to all contacts. We see that the second area of choice, if you will, was the to slow the spread of the virus, which is correct, followed by communicating signs and symptoms. Next slide, please. Sorry, I think I cut out for a minute, my apologies. So let's talk a bit about how contagious COVID-19 is, which helps home-based care workers to best discuss COVID-19 with their patients and families, and provides useful information for contact tracing. First, because the route of transmission is from one person to another, it's easily communicable. It's an easily communicable virus, which poses a challenge for disease control. COVID can infect people of all ages without exception, noting that symptoms generally appear between 2 to 14 days after exposure, with most people showing signs on day 5 from exposure. If by day 10 someone does not show symptoms, they're more likely to never show them, keeping in mind that even if there are no symptoms, someone can still have COVID-19 after an exposure. Next slide, please. So while this slide reinforces that those who are symptomatic, 15% of people may have severe symptoms and 5 may require mechanical ventilation. The figure also above also provides a general overview of those who do not show symptoms and includes all age groups. Note that the percentage of asymptomatic people is higher in the pediatric populations, which contributes to the transmission of infection in community. This is especially the case with our adolescent populations when appropriate prevention measures are not in place. Next slide, please. So for those who present with symptoms, initially the patient may develop a fever, but not always. Other common symptoms that can appear include joint pain, conjunctivitis, and for kids, more commonly nausea and/or painful sores on their toes, soles, or feet. One of the most specific signs that we see associated with COVID is the loss of taste and smell. Again, we encourage the use of graphics like this with patients and families and community member, as it's a concrete way of helping people to understand what COVID symptoms are. Next slide. There are a few ways to identify patients with COVID-19. The symptoms of COVID-19 can be confused with those of other diseases, so it's important to try to find out if the patient's been in direct contact with someone who has COVID. Direct contact means living or working with someone who has the disease, or simply having been within 2 meters of someone with COVID without adequate minimum protective equipment, such as the use of a mask or hand hygiene. It's important for the home-based care worker to find out how much exposure one person has had with another person who has COVID. The high-risk contact would imply being in front of a person in less than 2 meters for a cumulative time of 15 minutes or more. When a home-based care worker identifies patients with COVID-19, it's important to conduct contact tracing to identify people who may have been in contact with that patient. Wherever possible, it's important to make use of diagnostic tests to confirm the infection. The patient should be referred to the nearest health center for these tests. Next slide. So just to recap, an asymptomatic person is someone with COVID who shows no signs or symptoms. A contact is a person who's been exposed to someone with COVID anytime between 2 days to 13 days after the onset of symptoms. And contact tracing is a strategy for interrupting the chain of transmission and providing care to those being identified with COVID. Next slide. So why is contact tracing important? Most specifically, contact tracing is important to contain the virus, slow down its transmission in the community, including through isolation and quarantine, which prevents other people from being infected and interrupts the chain of transmission. And of course, to identify those with COVID and provide them the best care possible. Next slide. When a contact is identified, the home care worker carefully asks the patient who they were in contact with when not wearing a mask, starting 2 days before the onset of their symptoms until the moment when their COVID-19 diagnosis was communicated to them, giving him or her time to remember and list the people. This graph shows us how a contact tracer has to ask questions about who those people that they may have been in contact with. The recommendation for those who are symptomatic is to isolate for 10 days from the onset of symptoms, and for asymptomatic to quarantine for 14 days from the last date of a contact with the infected person, watching for any signs and symptoms. Thank you, Amir.
Thank you so much, Sarah. Thank you. I believe you have touched upon some of the very important aspects of home care, and we look forward to the participants asking specific questions about your slides, as well as your great experience that you have not only in your home state, California, but also elsewhere. So thank you. I would like to invite Dr. Sarah Rivera from Honduras to present her slides. So as I said, Sarah Rivera is our leader in the field, leading the home-based care interventions. And her work, in fact, affected not only people in Honduras, but also beyond Honduras. So Dr. Sarah Rivera, please begin your presentation. And just a reminder for the participants that we are not trying to turn on the video, because some participants are joining using their phone and it may draw a lot of bandwidth. So based on our experience, we decided not to project video unless we go to the question and answer session and briefly project videos of the panel members. So Dr. Sarah Rivera, all yours, please.
Thank you, Mir, and thank you all for the opportunity. With the following slides, I will try to provide specific recommendations related to the care of patients with mild COVID-19 at home. And I also will briefly discuss oxygen therapy for those patients who, for some reason, must receive this at home. Next, please, Gabby. So I will briefly be providing recommendations on these 5 important aspects: at-home isolation measures, treatment, specifically pain and symptom management, and basic preventive measures, identification of warning signs, and identification of the nearest healthcare center in the event where medical care is required. So starting from isolation at home, I will not go into much detail. Sarah has explained this very well. Both isolation and quarantine are two methods that help reduce the risk of infection by separating the sick from other people. And isolation is basically indicated under two circumstances. First, the patient has symptoms, and either that person is suspected or confirmed. Depending on the guidelines or the region you are, the days may vary, but in general, it's recommended that they stay in isolation for at least 10 days. And also people that are asymptomatic but have a COVID-19 positive test, it is also recommended that stay at home for at least 10 days since the confirmation of the diagnostic tests. It is also important to explain to other family members that when isolation is indicated for a patient at home, all those that live in the same house must be quarantined, ideally in a space within the house, but other than that occupied by the sick person. If the patient requires assistance, then the caregiver should try to follow all the recommendations aimed to reduce the risk of infection, like correct mask use and hand hygiene. One family member should be assigned to be the caregiver. Sorry, I will talk more about how to choose the caregiver in a few slides. But I just want to say that this person that is the caregiver should be free from high-risk conditions that predispose to severe COVID. We will talk about it in a few slides. The recommendation is that we assign an exclusive room and bathroom for the patient, but this is not always possible. And this is actually a major concern in my country as well. And if this is not possible, the recommendation is that people place a bed. As you can see, well, this is in the orange box. Place a bed or a mattress for the exclusive use of the patient as far as possible from the rest of the family. And also the bathroom can be shared, but it is important to disinfect after use from the patient. It is also good practice to keep the room ventilated. Opening windows is good, but fan use is not recommended. Fan use can increase the risk of infection of other pathogens, and not only SARS-CoV-2, and also raise dust, so it is not recommended. Next, please. We have some pretty images here that we can actually use, and we encourage the use of them to educate patients and families. Also, it is important, or it is recommended, that we set aside eating utensils for the patient. This can be washed with common dishwasher soap. And also the disinfection of high-touch surfaces, like we see in the image, like keys or doorknobs, tables, or the bathroom. Disinfection can be done with either bleach at a low concentration, 0.1%, or if it's not a big surface, it can be done with alcohol too. Talking about the caregiver, here is a list of high-risk conditions that predispose to severe COVID-19. As I said, these people should not be chosen as the caregiver for a patient at home unless no one else is available. As we can see, these are mostly chronic diseases like kidney, lung, heart diseases, but also age is important, and overweight and obesity, and we can't leave out pregnancy as well. Now that we're talking about the caregiver, you'll remember that Sarah presented the role of the healthcare worker a few minutes ago. Well, the caregiver also plays a very important role in this process. And here we list some of the important tasks that the caregiver needs to undertake. For example, the caregiver needs to guide and educate the patient with all the tools, the information, the recommendations that have been provided by the healthcare personnel. This should be done without increasing fear. The caregiver should be attentive to the presence of warning signs that we already mentioned, and seek medical attention if one of these or there's an deterioration of the patient. Maintain constant communication with the patient. This is very important to attend their needs, answer their doubts, and not only that, but also provide emotional support to maintain the patient's well-being. The caregiver should not only pay attention to the patient, but also to family and other household members. So the caregiver should have enough information on how to prevent further infection at home, and also identify COVID-19 symptoms for the other family members in the environment. Also support the patient in treatment and other measures. For example, giving medications, providing oxygen, cleaning and disinfection of the room is ideally, it is recommended that this be done by the patient, but sometimes it will not be possible. So the caregiver can help, always taking all the safety measures that we mentioned earlier, and managing waste. Now we will pause for a second for a poll question, and I encourage all of you to participate. So the question reads like this: medications recommended to control fever in patients. Option A, we can use acetaminophen. Option 1. Option 2, acetaminophen or ibuprofen may be prescribed. And option 3, ibuprofen. So we encourage you to participate, and we will leave a few seconds. Okay, we now have our answers. I can see that most of the audience have chosen acetaminophen, and then acetaminophen and ibuprofen. I will try to answer this question in our next slide. Thank you very much for everyone who participated. So talking about pain and symptom management, rest should always be indicated and practiced whenever possible. And it is also important to have a balanced diet, drink plenty of fluids. And one concern that arose early in the pandemic was about the use of ibuprofen and the risk of worsening the disease. It has now been shown that ibuprofen does not worsen the disease and can be used to relieve pain and fever, as well as acetaminophen. However, it should be used with caution in patients with renal failure, hypertension, and it should not be used during pregnancy. Next, Gabby, please. Now talking about oxygen therapy at home. It is important to educate patients on what the normal oxygen saturation value is for a person who has mild to moderate COVID-19 and is at home. This oxygen saturation goal differs from the one that is used for patients cared in hospitals, but for patients cared at home, oxygen saturation should not be less than 92%. Healthcare personnel should educate the patient, and not only the patient, but also the caregiver and all the family household members on how to use the medical equipment to provide oxygen at home. Here we can see an image that it is very useful to educate patients, and we encourage its use. Here, later in the section of tools and online resources, we will share how you can access the home-based care guide. But this is an image that isn't the guide and is very useful to educate patients when it is necessary to indicate oxygen at home, because for example, you can see here what is the oxygen goal saturation and when oxygen needs to be provided or even increased if the patient is already under oxygen therapy. And we know that not all patients will have access to a pulse oximeter. So it is important to explain to the patient other signs that are important and that show that things are not going well. For example, finding it hard to breathe, or and all of these warning signs should promote the seek medical attention. And this is where, like, we come to this point that all patients care at home should be very well aware of all the warning signs that should make them go seek medical attention at a healthcare facility. In our next slide, this is a very useful image also that we can, useful to educate patients when it is necessary to indicate oxygen at home, because here we can see all the equipment that is required, and we can easily explain to them what is the purpose of each item and introduce them on how to use it. So this is a very useful image. Now let's talk about a little bit about basic preventive measures in the home: hand hygiene, mask use, food preparation, laundry recommendations, surface disinfection, and waste management. I know that there is a lot to talk about each of these items. I will try to summarize and provide the most practical recommendations. So let's start with hand hygiene. Well, as we know, hand hygiene is the most cost-effective measures to reduce infections. And depicted in this image, we see 8 important moments of hand hygiene at home. These are all moments that help reduce the transmission of pathogens in general, not only SARS-CoV-2. I won't get into much detail, but this is also an image that it's very useful to educate patients and have to comply to these 8 moments. The hand hygiene technique may not be the same as the one we know and practice in hospitals with all the steps recommended by WHO. The important thing here is to educate patients on the minimum duration, remembering that for hand hygiene with soap and water, the duration is a little bit longer, 40 to 60 seconds, than the use of an alcohol-based hand rub. And it is useful that, well, sometimes people don't want to count the seconds. So, for example, for a hand hygiene technique with an alcohol-based hand rub, people can sing "Happy Birthday" 2 times until the hands are completely dry, and that will make up about 20 to 30 seconds. Now the correct use of face masks, which is another important aspect in prevention. Today, I just want to highlight recommendations about the valved masks or the mask with filters. We can either have K95 or N95 with filters. People use these masks because they feel more comfortable. They can breathe easily. However, they should not be used. They are not recommended because they protect the user very well, but not the people around. Infectious droplets can come out from the filter or the bulb, and and the other people be at risk. So people in general, not only the sick, should avoid using these. Another important thing that I want to talk about is recently US CDC published these recommendations on how to improve effectiveness of a medical and a cloth mask. Basically 2 ways that we see here in these 2 images. The picture on the right is a knotted ear loop you can see and tucked inside medical procedure mask. And the picture on the left, you can see someone wearing a cloth mask over a medical mask. So exposure to potentially infectious droplets or aerosols decreased by about 95% with either of these 2 methods. Important to know that cloth masks should be washed daily. And here in these 2 slides about donning and doffing a mask, I'm not going to go into a lot of detail, but a common mistake is not to wear them appropriately. We need to educate patients that the color side should always face outward, and that the metal band should always go on top of the nose. Hand hygiene must be performed after accidentally touching the mask, and also before and after donning and doffing of the mask. So here you can see an image about donning of the mask or putting it on. And then in the next slide, you can see the procedure to take off the mask. And you can see that washing your hands is a very important step in the process. Preparing food, even though it has not been demonstrated that we can acquire the virus through food, it is essential to wash all vegetables and fruits before consumption. And it's also essential important to recommend avoid eating foods that have not been prepared at home, or simply foods that is not known how they were prepared. So those are like the basic recommendations. And also start washing less dirty vegetables and fruits before washing the others. And I believe this is my last slide. No, this is the second to last slide. Just recommendations on laundry. Remember that there is an indirect way of transmission. So we should avoid shaking dirty laundry to minimize the possibility of dispersing the virus through the air. Important not to forget using a mask while handling dirty clothes, and always perform hand hygiene after manipulating dirty laundry. One important thing is that, sorry, Gabby, patients' clothes, this recommendation changed a few weeks ago, can be mixed with the family's clothing. It was said before that they should be washed separately, but now they can all be washed together. This is actually my last slide. Just important recommendations on bleach use. 3.5% is the most common concentration of bleach sold in most regions. That is why we have that here in the slide. A common error is that people not always store the prepared dilution in an opaque bottle away from light, and light can shorten the shelf life of bleach. So it is important to educate patients on how to store it. It should be in a dark room temperature area, and ideally it should be changed every day.
Thank you so much, Dr. Sarah Rivera, for a great presentation. In fact, you know, with the vaccines coming and countries are receiving some and waiting for the remaining batches of vaccines to arrive, it's extremely important to make sure that we have in place all the other very important, very effective public health measures, like having the masks on, making sure that the hands are washed on, you know, whenever we touch anything that may be, you know, infected, or you know, keeping a proper social distance in public. These are extremely important measures, even for those who are vaccinated. I'm personally, in my family, we are all vaccinated, but we are still trying to abide by the CDC and WHO recommendations and make sure that we have those measures in place. So thank you so much. I also would like to thank the participants for being great voters. You know, the voters turnout has been perfect. You know, we have almost everyone who voted on the questions that were asked. So I also would like to request participants to start posting their questions for each of these presentations. So with that, I would like to invite Dr. Lindsay Farrant, who has extensive experience in palliative care and will have excellent recommendations for us. So Dr. Lindsay Farrant, all yours.
Thank you, Dr. Ramsay. So I want to start just by thanking our asset team, as per this slide, just to recognize their support for the guidelines that we developed on palliative home care for healthcare professionals and for family members. And also want to acknowledge Sister Corinne Payne for her extensive work on these guidelines, and along with our colleagues, who I also want to thank for the pointers that have come into my presentation, and also especially the cases that I'll be presenting this evening. So the next slide, please. So I really want to anchor our discussion on the WHO definition of palliative care, which really speaks to what palliative care is as being an approach. And that approach is aimed at improving the quality of life of our patients and their family members. And how do we do that? Well, we generally in palliative care treat patients with life-limiting, life-threatening illness, and we aim to prevent and relieve suffering. And we do that by identifying what the suffering is, impeccably assessing it, and treating the patient holistically for the suffering. So the next slide, please. So I find this graphic from the University of Washington really helpful, because it helps to place palliative care for those that have less experience with palliative care. And it really shows palliative care is the umbrella, which is the approach for improving quality of life for patients with any serious illness. And as part of palliative care, but not the only part of palliative care, is end-of-life care, where we care for people who are entering the last phase of their life. And hospice is a model of delivery of end-of-life care, but not the only model. And many patients may be in a hospice, but may actually choose to have hospice care or general palliative care at home. So really our aim in palliative care is to improve the patient's quality of life. And how do we do this? We do this by integrating palliative care into the management of their disease-directed care. So why palliative care for COVID? I just really want to highlight, before I talk about COVID patients, COVID-negative patients with palliative care needs have been a concern for palliative care specialists the world over. And certainly in the experience of my colleagues, they have struggled, and therefore we've aimed at looking after these patients carefully at home. And the principles of palliative care apply to COVID generally, because as we've been hearing, many patients are symptomatic. So essentially, all patients who are symptomatic with COVID could have essentially a palliative care approach for their symptom management. But then, of course, we have the patients who have really severe disease, and they may be in hospital. They may not be a good ICU candidate. And therefore, for those patients, it really is important to integrate a palliative care approach. And then, of course, you have patients who may worsen despite optimal ICU care, and they would also benefit from palliative care. But then there's a different group of patients who have made an informed and voluntary choice importantly, with the discussion with their healthcare provider who knows them and who they trust. So they can have a really properly informed discussion where the patient may choose to stay at home, where the healthcare practitioner can attend to them daily. But then obviously, sadly, in this pandemic, we have had situations where the health system is overburdened and patients haven't made it to hospital and have sadly died at home before they could reach hospital. And then also a group of patients who are recovering from COVID. They may have extensive complications. They've been in ICU a long time, for instance, and they require extended supportive care. And that is also an appropriate place for palliative care to be integrated, and probably in the home for an extended period. And perhaps we're starting to think about long COVID and where we might engage with patients who have needs that need support. Okay, so the next slide, please. So I'm going to present this evening 2 cases. And the first case is of a frail elderly patient who lived in an old age home. She was independent, but had a very clear advanced care plan, and that was that there would be no hospital admission. The patient did not want it, and the family agreed this. And it was in agreement with the healthcare practitioner. So this patient was diagnosed positive of COVID and rapidly deteriorated over 6 days. The home had oxygen available, and for her shortness of breath, which was the main symptom, oxygen was provided. Codeine phosphate was used, and successfully so, and her SATs remained at around 93%. The patient struggled to prone. But then on day 5, she suddenly got more distressed, and they decided to stop the codeine and put the patient on morphine solution. And the standard starting dose for dyspnea, for shortness of breath, for morphine is 2.5 milligrams given 4 hourly. And this was suitable, but the dose did need to be increased to 5 milligrams 4 hourly with good effect. On day 6, it was clear that this patient was entering the dying phase of her disease, and the symptoms were increasing. So the healthcare practitioner started the syringe driver, and in that syringe driver were medications for symptom control purely. So haloperidol for agitation, and also to prevent nausea from the morphine, which was given for shortness of breath, and then midazolam for agitation and distress. This worked well, but in the last hour of the patient's life, she became more distressed and agitated. So an extra dose subcutaneously of midazolam was given with very good effect, and in the end, the patient died very peacefully. So that is the first case. And then the second case is also a frail elderly patient at home this time. So this patient had a number of comorbidities and a specific family member present and able to care for this patient 24/7 with help from some caregivers. And the plan for this patient, again, was the decision to stay home and not to go to hospital because of comorbidities and personal choices. The most difficult symptom for this patient was a cough. And initially, codeine phosphate was used, but it didn't work. And because this patient was opioid naive, the switch to morphine was at a slightly higher dose than we would normally use, but appropriate for the step up from the dose of codeine she was on. And given the renal insufficiency, a dose of 8 hourly instead of the usual 4 hourly was given. But this was sufficient and helped adequately for the cough. But alongside the morphine use, the patient obviously then struggled with constipation, and this was very difficult. And there needed to be a balance between the laxation and the patient's need to and desire to use a commode and not have a nappy in place. Another symptom that was difficult was sleep. And for this, there was an additional benzodiazepine used to assist with sleep. By day 7, this patient was very weak with low SATs, respiratory rate of 32, and very labored breathing. And the family were expecting the patient to die. However, the patient improved and recovered from the COVID, and then subsequently went on to die at home a few months later. But what I want to highlight that came from this family was that there was very important emphasis on basic care, besides what I've described in terms of the medical management: washing, mouth care, massages, and physical support for the patient while coughing. So, and then also the patient, from a psychosocial and spiritual point of view, the patient was afraid. But the family was supported and able to be present and help the patient talk through these fears and wishes. And I want to highlight that this is something that families generally can't do on their own. They really need daily support to deal with these difficult scenarios. So for my next slide, I just want to highlight some key points that come out in our guidelines. And the one is that we need an ethical approach, and there's some quite specific pointers in our guidelines on how to address the ethical issues. And then also communication. Communication is foundational to palliative care, and we need to be compassionate in our communication, but we need to be clear, and it may need to be repeated a number of times. Advanced care planning is foundational, but it's not necessarily always happening. So what is advanced care planning? Well, it's a discussion between the healthcare practitioner and the patient and family. What are their personal goals, values, preferences, so that an individualized care plan can be created for each patient. Ideally, this is done in advance, but in COVID, this is often happening in the scenario of really a significant worsening. And that's clearly much harder. And we often use the phrase, hoping for the best, we'll be preparing for the worst. So holistic care is important. I've alluded to that. We care for the patient from a physical symptom point of view, psychosocially and spiritually. And I've got there the logo of the Palliative Care Practitioners, Association of Palliative Care Practitioners in South Africa, who wrote guidelines for COVID symptom management and care. And we have relied heavily on those for our home care guidelines. And then obviously in COVID, we need to talk about bereavement care. And it's important that we need to be mindful that this may need to happen virtually in our pandemic situation. So my last slide then is just a few final practical tips to wrap up. Teamwork is essential, and it's really important for the healthcare practitioner to have the team to rely on to support them, but it's important for the family and for the patient to have direct contact, ideally daily. It may not be in person, it may be virtual. Something that some team members that I know used was an app which was compliant with the regulations for personal information, and that was helpful for the sharing of information between team members. Helpful to find advice from physiotherapists on proning patients and making PEEP bottles, for instance. Syringe drivers are really useful for end-of-life care and symptom control. This is delivery of medication subcutaneously. Our guidelines are clear on how to use those. And then reiterating again what's been said around PPE. It's not really known to patients and even carers who care in the home how to use PPE appropriately. So really important. And then just the final note on self-care for carers and healthcare practitioners, with what my colleague described as constant debriefing because of the rapidity of change of the clinical situation of many patients. So thank you.
Thank you so much, Dr. Farhan. Great presentation. In fact, it has already stimulated some questions, and I would like to request you as well as other panel members to keep an eye on the question box and be ready for answering those questions during the question and answer session. So thank you so much. And I would like to invite Dr. Sarah Rivera again to tell us about the great story of the work that she led in Honduras, that in fact not only was engagement with the frontline health workers, but also she was able to work with the ministry and change the policy and guidelines of the ministry in a short period of time in order to strengthen home-based care for COVID-19 patients. So Dr. Sarah Rivera, please share your story from Honduras and El Salvador.
Thank you, Mir. Thank you again. And thank you for this opportunity. I want to quickly share, like Mir said, our experience with COVID-19 home care in Honduras and also in El Salvador. Okay, and I just want to say that I am speaking on behalf of a wonderful team that has supported this activity in my country and that I am very honored and happy to be part of. As in other countries in the region, at the beginning of the pandemic, great importance was given to strengthening the in-hospital management of patients with COVID-19, and very little importance was given to that large percentage of cases that are mild and are managed at home. So this is when, in collaboration with the Ministry of Health, we developed a home care guide for healthcare workers in the community to facilitate education to patients and families. And we know that it is extremely important that people in the community know how to prevent transmission of the virus to others and when to make the decision to seek care at a healthcare facility, and also how to control symptoms. This gap in the COVID-19 response was identified, and after a long process, maybe not too long, multiple meetings and coordination with the Ministry of Health, finally we adopted the guide for Honduras. And now we are really happy. It is now approved as an official document and it is being used by many. And next slide, please, Gabby. And it does not stop here. We are very happy to share this. We are now in the process of training healthcare workers on the content of the guide, especially healthcare workers in the communities. And this way they can provide better patient care with practical evidence-based recommendations. Here in Honduras, we have conducted 9 trainings to over 400 healthcare workers. We recently started with the trainings the last week of March. And the idea is to train trainers in the 20 regions of Honduras so that they, in turn, through a cascading training plan, can educate others in the regions. This way we can train as many healthcare workers as possible to improve the quality of care provided in the communities, and also to provide more support to families. You can see here in the slide that we also have a pre and post test. We like to measure knowledge, and we can see here the change in the learning curve, that it has been impressive. Also, this guide has been adapted to, and next, Gabi, please. This guide has been adapted and used in other countries and regions. For example, El Salvador. And next slide, please, Gabi. And I would just like to thank Dr. Daisy Ramirez from El Salvador, who kindly provided this information that you're seeing here now on the slide. El Salvador has conducted trainings on home-based care for 11 months now. Health Policy Plus, the Ministry of Health, and the ANES, or National Association of Nurses, have supported all of these activities. And it is a great achievement from El Salvador to have trained more than 2,000 healthcare workers from all across El Salvador. Healthcare workers that are in the communities and now are providing quality care to patients managed at home. In our next slides, Dr. Daisy also shared some of the trainings that have been done in El Salvador. Most of these trainings have been conducted face-to-face in 8 departments in El Salvador. And I would just like to, this is a summary, but I would just like to say that for the team, it has been a wonderful experience to be able to work along with the Ministry of Health to improve the response to the pandemic in Honduras and also other countries. Thank you.
Thank you so much, Sarah, once again. I would like to invite Dr. Jane Erin Nabakoza, who is working with the Ministry of Health of Uganda, a country that I love so much, where I spent some years of my life. She is a pediatrician and a public health specialist. So Jane, please unmute yourself and please begin your presentation. I know that you are using your phone. I hope you don't face any technical problem.
No, I won't. Can everybody hear me? Here I could say good evening and then good morning. Mine is to briefly share the experience of Uganda in adapting the home-based care guidelines. I'm grateful to the team I'm working with, Pauline Okello, and the Commissioner, Community Health Division, Dr. Openso George, Brenda, and the rest of the team and the implementing partners that have made this work possible. Next slide, please. Yes, are we all aware that as a country, we got our first case in March 2020, and by July, 50% of the country was in phase 4 of disease. What phase 4 means here is that at that time, we were reporting a number of community transmissions with a lot of infections whose contact you wouldn't trace, with a number of cluster infections. And so, fortunately for us, 75% of these cases were either symptomatic or mild cases, and yet they were overwhelming the already stretched healthcare facility and healthcare systems. And then deterring patients from accessing other essential healthcare services. So the chairman, National Task Force, His Excellency, the President of Uganda, guided that since there were ongoing efforts to streamline community engagement, that we consider starting home-based care. Next slide, please. So I forgot to mention one thing. So January 2021, we got to learn from UHSS that there was a guideline available on home-based care, and we looked at it and decided to adopt it. And as I speak, we have done a number of engagements, consultations in order to try and adopt the COVID-19 home-based care guide. a practical guide for health workers that was developed by the Health Policy Plus, and thank you so much, project to Uganda, and the process of adaptation is ongoing. As you can see, what you see in the picture on one side is the previous version, and what you see is what Uganda is currently trying to adapt. A number of changes are going to be, I'll mention that the number of things we have revised, like the pictorials, we made sure that we're changing to those that are actually context specific for Uganda. You'll note that we agreed after very many consultations that we're going to meanwhile do away with oxygen use, because as a country, our system is still in the process of getting revamped when it comes to oxygen service delivery. Most of our patients cannot easily access oxygen at home, so we agreed that for the time being, things like oxygen are going to be out. Next slide. So the process of adaptation has been as follows. We started by number one. We started by a joint review of what Health Policy Plus had the picture I saw in the previous slide. We went ahead to align the content to what we had as Uganda. Number three, we went ahead to contextualize pictorials. This was done with the help of the Health Promotion Division of Ministry of Health. And as I speak, we are reviewing the final copies in collaboration with the case management pillar of the incident management team of Ministry of Health. And we near the end of this process and are awaiting approval. And so far, what we've agreed as a team, guided by the Commissioner, Community Health Department, is that since we already had an implementation guide for home-based care, near approval, that document is ready, and the minister, I think, looked at it, and the team, and they feel it's okay. So we agreed that we're going to take this document together with the implementation guide to the strategic committee of Ministry of Health Uganda for approval. After this meeting, I'm very sure we're going to follow this up and make sure it happens. So the stage at which we are is getting the guide approved. Next slide. And thank you so much to HSS. So, as a country, how have we come to implement home-based care? Allow me to mention here that in as much as we just adapted the guidelines of home-based care from Health Policy Plus in the January month of 2021, there were already ongoing processes to make sure that whatever we plan around home-based care will fit into the existing systems of Ministry of Health Uganda. One of the things we've done as a country is ensuring that there is a proper coordination mechanism and oversight at all levels of implementation. You'll see lower down that we have structures of implementation. And since this is going to be home-based care, there are structures through which you must go in or before you get to the individual in a home. So we made sure that we identified existing structures, we assessed their functionality, and we're in the process of making sure that those that were dysfunction are given terms of reference, and that we identify focal persons for home-based care. Like, for example, you as you may be aware, we have the district task force. Lower down, we expect to have the COVID-19 sub-county task force, then have a similar task force at the parish level, and then something at the village level that is the nearest point for the patient. And at each of those, we expect to have a focal point person with clear terms of reference that will make her accountable and participate effectively and perform. So, so one of the things we did was to assess, and then the ongoing thing is that we are trying to revitalize. The other adaptation that we tried to do was partnerships and collaborations. As you're well aware, the COVID pandemic was something that was an alarm and yet an opportunity to streamline healthcare systems to most countries. So it wasn't possible for us to quickly identify funds like for the newly introduced things like home-based care. So we've done a lot of partnerships. We started by identifying sectors and partners that could collaborate with us. And then we dialogued and consulted them. We also did partner mapping. As I speak, most of them have supported the rollout and implementation of the community engagement strategy, which is going to be a framework and a framework that will guide implementation of home-based care. So as I speak, we know which partners are where and what they can do in terms of supporting the implementation of home-based care. We've also done lots of advocacy. We've sensitized leaders. We've empowered them to own home-based care and community engagement. The other we're doing is capacity building. We've done a number of trainings as I speak. We have trained 26 national trainers. We've been able to train a number of national trainers in 46 districts. These were mainly sourced from health centers as health facility in charges and health assistants, because they're the ones that they directly deal with community health workers who are going to be the frontline providers that will support home-based care. And then we went ahead to adopt the available guidelines on home-based care. What we plan to do after fully adopting this home-based care guide for health workers, we plan to extract some content for the community health workers in form of a job aid, where you have words on one side and pictorial on the other side that will guide the community health workers to support home-based care. But we also intend to have flyers for the caretakers and the patient. All this is in the process. Since these don't need approval, it's something we plan to do in one sitting. And finally, integration. As you'll see later, there already are existing opportunities for integration, like an existing referral system, the existing VHT system that we're already doing community-based disease surveillance. So we are trying to include the surveillance that will support home-based care in the activities of the community health workers. And finally, we are trying to streamline the community engagement. It so happened that at that time we went into phase 4. The Ministry of Health was in the process of streamlining community engagement. There was already a community health systems committee in the Ministry of Health. And all we did in order to make it multi-sectoral was to collaborate with the technical intersectoral committee. And this is helping us to make sure that we work together with the other sectors. And as I speak, we already have a community engagement strategy that clearly spells out the structures and role players at different levels. This has been approved and disseminated. Next slide, please. Here is a very good example of the existing referral system into which we are integrating the different components of home-based care, like contact tracing, screening. You can set some point the VHT screening, and then they are reporting to the LC1 or the health worker, and the patient they are informing the district task force, and the patient is being followed up to be sent for testing. But fortunately for us, even the introduction of the rapid diagnostic tests for COVID has been rolled out into a number of lower facilities. So the services are getting closer to the people. So after the patient has been tested at the facility, they are assessed. If they are not eligible for home-based care, they are sent to the nearby set up COVID treatment unit. But if they are eligible, they are sent back home, and the VHT is informed for home-based care. You note that alongside that, even the other effects of COVID on the patients and the community are catered for, like gender-based violence and any of those others. And then continuity of services also continues against that same referral system. So we are integrating all the home-based care activities within the existing community surveillance and referral pathway, as you can see. So this is a very good example of some of the adaptations that we have done in order to effectively implement home-based care. Next slide, please. Next slide. So clearly here, what I was trying to show is the advocacy levels, the advocacy that we've done as an adaptation. That letter you see was a letter written by the Prime Minister. And that is it includes the government commitment to support community engagement. And remember, community engagement strategy is the platform we are using to implement home-based care. So this is government commitment. So as you can see, that is one very important tool for advocacy as an adaptation. But also you can in the picture there you're seeing the Deputy Prime Minister launching community engagement and home-based care in one of the districts, and that's Moyo district. Below him is the commissioner trying to communicate government position on community engagement strategy and home-based care, because you can see engaging communities in the fight against COVID, major approach being home-based care. Next slide, please. So, so far we have achieved a number of things, like for example, the document you see, that is next slide. Okay, no, it's okay. The document you see, no, kindly go back. I need to elaborate. The National Community Engagement and Strategic Plan for COVID-19 Response. This document provides a framework for the implementation of home-based care, and it was approved and it's already disseminated. A number of districts have received copies. Capacity building has happened. Mapping of partners has happened, and then there's already an existing framework for implementing home-based care. Next slide, please. Next slide. So briefly here, this is the structure that will guide us to implement home-based care. I will not go through it because of time. Lessons learned, one of them is that leveraging on existing resources is very key, and through collaboration and integration, it facilitates quick implementation of home-based care. Communities, we've learned that communities and families are actually able to participate in the prevention and control of any disease. All they need from us is information, guidance, and technical support. The other is that appropriate partner coordination and multi-sectoral collaboration facilitates identification of opportunities and resources that will facilitate home-based care implementation in return. And then also the integration of home-based care into district annual plans and operational plans facilitates mobilization of resources and quick implementation of home-based care. Next slide. So we still have a few gaps. HBC interventions are not yet prioritized in some district plans and budgets. We are working on making sure they are prioritized. The dysfunctional coordination and oversight mechanisms at the lower levels, like sub-county, most of them are dysfunctional. Parish, village, they are dysfunctional, so we need to revitalize them. Progressively reducing levels of risk perception for COVID by communities. Many of our community members think COVID is no longer a problem. The non-availability and limited access to guidelines, as you can see, that we're just going for approval, so they are not available, and so are data collection tools. As we speak, the little data that we are getting in is an innovation. We are getting it through regional referral hospitals. Then the inadequate capacity building for the village health teams and community health workers. Most of the trainings have happened up to district trainers level. We've trained very few VHTs as I speak. I thank you.
Thank you so much. It was a great presentation, and I very much hope that at some point we will have an opportunity to have frontline health workers from Honduras and Salvador have an exchange with your colleagues, Dr. Nabakuza, to see what are some of the lessons learned that could be shared between the two countries. And it's also fascinating to see a guide developed in a different continent, but with similar situation has been adapted and used in the context of Uganda. So thank you so much. So participants, we aim to end this webinar sharp at 2:30 Washington time, which is 14 minutes from now. So I would like to request Robert Okoma, Mr. Robert Okoma, to briefly go through his story, the very interesting story that he went through the infection himself and how he was able to use the home care guide recommendations for himself as well as for his family. So Mr. Robert Okoma, the floor is yours.
Okay, thank you very much. Good evening and good morning. Thank you very much to the previous speakers. Now that you've heard from the frontline team, it's time that you hear from the patient. I'm just going to briefly share my experience as a patient, and it will take just a couple of minutes because we don't have a lot of time. So next slide, please. Yes, so it's my experience. It's all started really with all my family members getting sick, and then going to hospital, and luckily for them, they quickly improved. But when it came to my own case, I couldn't improve. So I finally went back to hospital for the second time, and they did a complete blood count test, and then they were telling me probably it's a bacterial infection, but I was feeling this extreme body ache, body pain, that I told the doctors that I need to do a COVID test because I was feeling something I had not felt before. Next slide, please. So immediately after doing the test, I actually started isolating that day. So I isolated myself in one of the rooms as I was waiting for the results. So I did the test on the 17th of December. On the 18th of December, I got the results, which confirmed which I was suspecting, something I was suspecting, that I was COVID positive. And I was immediately put on the means of health treatment plan for those symptoms, which was really azithromycin, paracetamol, vitamin C, and zinc tablets for 7 days. Next slide, please. Yeah, so of course, after getting the results and the medicine and all this, I informed the family members and the close friends about what had happened and encouraged them not to visit us, so that we could, everybody at home, that we simply stay home and avoid interacting with other people outside. But of course, the biggest challenge was this was not easy. As for them, life had to go on, and it was quite hard to contain them around the house. So once in a while, people would escape and kind of interact with the people in the outside world. But I was still really strong, and I was, despite being positive, I was still monitoring what was going on. So I remained in contact with the the doctors where I tested it. That picture that you saw in the previous slide, it's called Doctors Hospital in Seguku, which is real near my place, and it's the hospital where we all go to. So they would actually come and visit me, come with an ambulance and check on me, check on the blood pressure, and sensitize my caregivers. And this continued beyond the 7 days actually that I was supposed to take the medication. But because the azithromycin comes in, there are 3 tablets in a pack. So after the 7 days, I asked the doctor, so what do I do? They told me, since you are still having the symptoms, take the remaining 2 tablets. So I went on for 9 days, and nothing changed that much actually. So they switched my treatment to cephaloxone and cephaloxone IV injections and the Dexa tablets for 3 days. Next slide, please. So after taking this, the injection for 2 days and the Dexa tablets, and there was little improvement, so we decided to get admitted to hospital after consultation with the doctors that were managing me. And so the idea was that I really had to check into the hospital because I was not improving, and they were worried things would not be very, very good if I continued staying home. Next slide. There was a repetition there, so just skip that. Go to the next slide, please. Yes. So, what are the key supports that I really had at home to know how to care about myself? So one was had this great, amazing, and supportive team. This really included my family, the UHSS team led by our chief of party, Dr. Samson Kirondo, who is a medical doctor, and my other colleague, Dr. Beta Tai. Dr. Beta Tai moved the mountains. Every day, every minute, she was checking on me and to make sure that things are going on well and comparing notes here and there. And I had other colleagues, friends who are doctors, of course, plus the hospital doctors that were checking on me. So it was a great team. I also had a lot of educational materials on home-based care, both shared by UHSS, including the newsletter, which we receive. But also, before I joined UHSS, I had actually worked with the Red Cross twice. And in both cases, I was actually involved in pandemic preparedness. So I have quite a lot of materials in home-based care that I'd never really used, and I had to bring them out to use them this time because now I was actually the patient. The other one is actually the equipment. I was advised to buy a pulse oximeter to monitor my oxygen levels, and this helped me a lot because I constantly had to monitor my oxygen levels while at home. And of course, the medication that I already mentioned that the doctors prescribed and that I was using, that was very, very helpful in terms of supporting me. Next slide, please. So, what are the key supports that yes, this was really a continuation of what I actually mentioned. It's just a repetition, but let's just skip this because it's the same slide that I've just talked about. So, what are the challenges I faced in home-based care? Of course, the first one was anxiety. Anxiety, of course, about especially the children getting exposed to COVID-19. The ministry recommends, like have a self-contained room. I didn't have that, so I was isolating in the visitors' room, which is not self-contained actually. So I had to use the same bathroom and had to make sure it's we disinfect it each time I went there, and maintaining proper hygiene by the caregivers to avoid infecting others. That was something else that was stressing me because sometimes things were not done right. Much as we emphasize that my things were clean alone, and sometimes you get somebody has picked a fork and they are mixing it with other things. And of course, so at the end of the day, the stress and the depression, it's the children can't come close to me. I can't allow them to come to me, and they're wondering what was going on. But I was talking to them, and because they had been watching on TV for some time about COVID, so they called corona. So they I actually have corona, so don't come near because you get corona. So they really got scared, and they would just look at me at a distance, and it was not good. Then of course the other challenge is compliance, especially by family members. There was a lot of propaganda out there on social media, on WhatsApp, on TV. People think this is a hoax. So despite the fact that I was actually sick, they were actually looking at me, but then they were on the other side. Then they also have this other information that and to actually make it worse in my own case, that actually my wife also had COVID, but she was not affected as much as I am. So now you can see it's another whole different scenario. For me, I'm fighting for my life, and then for her, she had the symptoms for a few days and things got well. So that was a big challenge. And then misinformation, I think that was one of the biggest challenges in terms of management and treatment. There was a lot of misinformation, but most of it actually misinformation. People are telling you, drink this, steam with this, garlic, I don't know, ginger and all. In fact, when I finally went to hospital, the first thing the doctors asked me that, how come you're home for close to 3 weeks and then your throat is okay? Because I got there so many people who had damaged throats and always forgot, and the doctors were saying that they were going to live with that problem for the rest of their lives because of the kind of misinformation that was flying around. And of course, it was really expensive in terms of this home-based care, because in my case, the doctors that were coming to really visit me were from a private, they are private health providers, and each time they were coming, I had to spend money, almost 300,000 Ugandan shillings. That's almost like close to $100, each time that they were coming to visit me. So, which was really expensive because our insurance company could not. They had stopped now handling COVID cases, so you had to pay out of pocket to pay for the services. Next challenge, please. Sorry, next slide, please. Yes, so how did I try to overcome these challenges? Of course, one, I had a couple of friends that had gone through the same experiences, so I would talk to them, listen to their experiences, they tell me what they did, and then, that kind of, gave me hope that I'll also go through this. And of course, reading a lot of materials that I had, like I said, I have quite a lot of materials on this. So I was having a lot of, materials to read that kind of helped me to overcome the challenges. And then before I really got weak, I was doing a lot of exercise. I remember I was sharing with Dr. Samson. I would update him on a daily basis. Today I walked 4 kilometers. Today I walked 5 kilometers. And then when it came to second week, of course, I got very weak. Just by the time I went to hospital, and then I could not exercise or even walk. I couldn't even walk a kilometer because I was very weak, because I had this serious cough that was non-stop. And of course, finally, the prayer was the other bit, because the other part, it came back to, I prayed like I'd never prayed before, because colleagues, a few of them would call me, and because I was coughing a lot, so I couldn't talk. So they would tell me, just switch on the phone, pick, and then just listen, and then we'll pray for you. And that's somehow gave me hope that, there's something out there that's. So that's how I overcame those challenges. Is this my last slide? I think this was the last slide. Is there another slide? Oh, yeah. Recommendations. This is the last slide, yes. So really, of course, you had you had the other presentation from Dr. Jane. So as you know, we are work in progress. So really, one of the recommendations from my own experience is, for the government especially, to take in interest in, people who are on home-based care, because there's a lot going on when people are at home there, so they really need to be followed up. And of course, monitoring these patients on a daily basis is very important, because things, from my experience, things can change from good to worse in a matter of hours. So you'll need somebody, like the VHTs or the government health workers from a nearby health center to come and monitor the patient, probably on a daily basis. Because ideally, then the health center would be able to, in position to counsel both the family and even the patient and caregivers, somebody really qualified, because really someone needs a lot of counseling. There's a lot that's going on. There's a lot of stress that really needs somebody qualified to support. And of course, not many people were in my position, for example, able to buy like some of the equipment and being able to pay for those services that I paid for. So it really important that maybe the government, health workers from nearby health facilities actually support such people to keep going. Thank you very much.
Thank you so much, Robert. I think this was an excellent story. A lot of lessons learned for the system as well as for individuals. So we are almost at time, and I'm not sure that we have time for question and answer. However, what we can promise is that we will put together all the questions and answer, and we'll share it as part of the materials that we are going to share. But allow me in this last 1 minute to go quickly through some of the reference materials that I would like to share with you. So Gavi, could you please quickly go through this slide? Yes, thank you. So this is the home-based care guide that's available on the HP Plus Health Policy Plus website, as well as on the critical care website. Next one slide, please. CDC has also some excellent materials on YouTube. You can use that barcode and get directly to the materials that we have on the slides. Next one. And there are also some excellent materials on Open Critical Care websites on how to calculate oxygen for patients who are being taken care of at home. So you can again use the barcode to go directly to the resources that we have on the slides, and also you can search the Open Critical Care website and get these materials. Next one. And the core group, in fact, has an elaborate guide on, some of the sections that, we talked about during the presentations, and you can refer, to the core group website as well. So we are at time. Thank you so much. It was, a great It was great to have you with us, and I would like to thank the presenters, the panel members from all the 3 continents. I know it's very late in Uganda as well as in South Africa, so thank you so much for joining us. We promise to share with you 3 things. Number 1, we will share a survey on, a satisfaction survey and its link so that you can share your feedback with us. Number 2, we will share with you the link for this, webinar so that you can download and watch it or share it with your colleagues. And number 3, we will also share with you the question and answer so that you can see answers to the questions you have asked. Thank you so much, participants. Thank you so much, panel members. The meeting is adjourned.